Every hospital has secrets. Every shift has mistakes. When the alarms stop, the truth begins. I had been a nurse for 7 years when it happened. 7 years without a single write-up. 7 years of 12-hour night shifts, short staffing, missed breaks, and alarms that never stopped screaming. The night Mr. Calder died, I was responsible for 9 patients, 3 more than policy allowed. The hospital called it crisis staffing. We called it a death sentence waiting to happen. Mr. Calder was a 62-year-old admitted for pneumonia, stable, improving. The kind of patient you expected to discharge in a day or two. He joked about the hospital food. He told me about his granddaughter. He thanked me every time I entered the room. At 2:17 a.m., his oxygen saturation dipped. At 2:19 a.m., another patient's IV pump alarmed. At 2:21 a.m., a confused dementia patient tried to climb out of bed. At 2:24 a.m., pharmacy sent a medication override warning. And at 2:26 a.m., I made the worst mistake of my career. The medication vial looked identical. Same color, same font, same size. The only difference was a thin red stripe I didn't see under fluorescent lights and exhaustion. I administered the drug. Within seconds, Mr. Calder's monitor screamed, heart rate plummeting, oxygen dropping, blood pressure crashing. I froze, then ran. Code blue, room 417. The room filled instantly. Too many hands, too many voices, someone shouting doses, someone else yelling times. But I already knew. I had given him a medication that slowed respiratory drive to a patient already struggling to breathe. He never woke up. The hospital chart later said, unexpected cardiopulmonary arrest due to underlying condition. No one asked about staffing. No one mentioned the identical packaging. No one questioned why a single nurse had 9 patients. I was offered support counseling and reminded not to speak to anyone outside administration. Mr. Calder's family never learned the truth, but I hear his monitor in my sleep every night. I worked triage in the ER, the front line where seconds mattered and assumptions killed. She walked in at 11:43 p.m. young, mid-30s, pale, sweating through her hoodie. Chest pain, she said, but it's probably anxiety. I hated when patients said that. It was never just anxiety. Her vitals were borderline but not alarming. EKG showed nothing dramatic. The ER was packed. Stretchers lined the halls. Ambulances stacked outside like a traffic jam. The attending barely glanced at her chart. Panic attack, he said. Discharge. I hesitated. She said the pain radiates to her jaw. He sighed like I was wasting his time. People Google symptoms. I printed the discharge papers. At 2:12 a.m., she signed them. At 2:26 a.m., security footage showed her collapse outside the ER doors. At 2:41 a.m., EMS brought her back in, pulseless, massive myocardial infarction. She died in the same department that sent her home. Administration called it a missed atypical presentation. No one was disciplined. I still keep a copy of her EKG in my locker, because sometimes the scariest thing in medicine isn't what you don't know, it's what you're told to ignore. The consent form was signed, the limb was marked, the checklist was rushed, and the surgery was wrong. The patient needed a left side vascular repair. The surgeon operated on the right. By the time anyone realized it, the damage was irreversible. The hospital settled quietly. The surgeon kept operating, and the nurse who tried to stop it, she was labeled difficult. That nurse was me. I was 3 months into my first nursing job when it happened. Night shift, ICU, the kind of quiet that presses against your ears until every monitor beep sounds like a gunshot. Room 214 belonged to Mr. Halverson, 72, septic shock. He was on multiple IV drips, vasopressors, antibiotics, fluids. The chart was thick. The orders kept changing. At 2:11 a.m., pharmacy sent up a new bag of potassium. The label looked right, Same concentration I'd hung dozens of times before. What I didn't know, what no one caught, was that the pharmacy software had duplicated the order. 2 potassium drips, running simultaneously. By 3:30 a.m., his heart monitor started throwing PVCs, then VTASH. I called the resident. They brushed it off. Electrolyte imbalance, keep monitoring. At 4:02 a.m., Mr. Halverson flatlined. When the code team rushed in, one of the nurses screamed, "Why is potassium still running?" Silence followed. His potassium level came back critically lethal. The room felt colder after that. Weeks later, risk management told us to chart carefully. No apology, no accountability. His family never knew the truth. I still hear that IV pump alarm in my sleep. The computer system went down for maintenance at midnight. Paper charts came out, something most of us hadn't touched in years. 2 patients, same last name, same floor. One needed insulin, one was not diabetic. Guess which chart I had? By morning, Mrs. Alvarez was unresponsive. Blood sugar, 22. Her husband screamed when they rushed her to ICU. The chart audit showed my signature. The insulin order belonged to the other Alvarez. The hospital settled quietly. I transferred units 2 weeks later. Her face still flashes in my mind every time I log in. I told the doctor something was wrong. Her blood pressure was dropping, oxygen unstable. She wasn't responding normally. He told me, "You worry too much." By shift change, she was in respiratory failure. She died before sunrise. In the chart, sudden unexpected decline. I filed an incident report. Administration told me to be careful. I quit nursing 6 months later. The surgeon marked my left leg with a black marker. I remember it clearly because I joked about it. "Guess I won't be running marathons anytime soon," I said. Everyone laughed. That was the last thing that felt normal. I was scheduled for a routine orthopedic procedure, repairing torn ligaments in my right knee. I'd signed the consent. My chart said right. My MRI clearly showed right. But somewhere between pre-op, shift change, and the operating room, something went wrong. In pre-op holding, a nurse came in and checked my wristband. She asked me what surgery I was having. "Right knee repair," I answered. She nodded, but didn't look up from the computer. Another nurse came in later. Different one. She glanced at my chart, then at my legs. "Left knee today," she said confidently. I corrected her. She smiled politely. "Okay." She didn't update anything. By the time I was rolled into the operating room, the surgeon was already scrubbed in. The drape went up. The lights burned overhead. I tried to speak again, but anesthesia had already begun. The next thing I remember was waking up in recovery. Pain shot through my left leg. I told myself it was just nerves, confusion, anesthesia haze. Then I looked down. A thick surgical dressing covered my left knee. I tried to sit up. "Something's wrong," I said. The nurse froze. She pulled back the blanket. Her face went pale. She left the room without saying a word. Minutes passed. Then the surgeon came in. He didn't meet my eyes. "There was a documentation issue," he said. They had operated on the wrong leg, the leg that was perfectly healthy. The actual injured knee, untouched. The hospital called it a never event. Risk management showed up before my family did. They asked me not to discuss it publicly. The corrective surgery happened 2 days later. I now have permanent damage in both legs. One mistake, one wrong mark, one life changed forever. He came in walking. That's what everyone remembered. 39 years old, fever, chills, complained of body aches and nausea. The ER was busy. Overflow patients lined the halls. Triage labeled him flu-like symptoms. Vitals were borderline. Nothing screamed emergency. They gave him fluids. Tylenol, sent him to observation. But by midnight, something changed. His heart rate climbed. Blood pressure dipped. Skin turned pale and clammy. The nurse flagged the chart. The doctor never came. At 3 a.m., his labs came back. Elevated lactate, rising white count. Classic signs of sepsis. The nurse escalated again. The response? He's stable. We'll reassess in the morning. By 5 a.m., he was confused. By 6 a.m., he couldn't breathe. A rapid response was finally called, but it was too late. He coded on the way to ICU. They shocked him twice. Nothing. Time of death, 6:47 a.m. The death summary read, sudden cardiac event. No mention of delayed antibiotics. No mention of missed sepsis criteria. The nurse who advocated for him was told she did everything she could. The hospital quietly updated its sepsis protocol weeks later. His family never knew how close he came to surviving if someone had acted sooner. Sepsis doesn't kill loudly. It waits. If these stories got your heart racing or opened your eyes, hit that like button. It helps the channel reach more people. Subscribe for weekly medical horror stories inspired by real events, and share this video because the scariest stories happen in real life. Comment below with your thoughts on these medical mishaps.